Hi, I'm Dr Saladina, Breast Endocrine Surgeon from Partner Hospital Kuala Lumpur.
Hi, I'm Dr Hilawati, Consultant Clinical Oncologist from Pantai Hospital Kuala Lumpur.
We want to highlight about the most common cancer affecting women in Malaysia.
And it's the most common cancer in women.
Pain is not the commonest symptom for breast cancer. On the contrary, pain is actually low in the list. The most common cancer is actually a palpable lump that is painless but increasing in size. So sometimes they don't present with a lump, they present with just thickening of the breast tissue. So I think women have to have this self-awareness. We need to do monthly self-breast examination. Of course, nipple discharge, skin changes, those are symptoms, but generally those are late signs. Generally for breast screening, it depends on age group. So if you are younger, like 40 and below, it is good enough to do a monthly breast examination plus an ultrasound breast. If you are older, like 40 years and above, then we would recommend mammography together with a breast ultrasound. And it's commonly done for screening every 2 years. Coupled with an ultrasound, we would actually also advise patients to add ultrasound to the screening package because of Asian breasts are generally dense. So dense breast means the breast tissue is very glandular. On mammography, you will not be able to see well.
Clearly.
If we picked up something on health screening, mammography or ultrasound, generally patients will get referred to breast surgeon. We will do a needle core biopsy. Biopsy is a procedure whereby it's often done under local anesthesia. It can be done either freehand, means you can feel the lump, you just put a needle directly, or using an image guided.
In the old days, it used to be big tumor, then they will have surgery to reduce the size of the cancer, then they will have operation. But actually how breast cancer is treated is based on the stage of the cancer, whether it's localized or locally advanced, or stage 4, which is metastatic, spread to other organs, and also depending on the cancer subtype.
When we biopsy the patient, not only we confirm the type of the cancer, whether it's coming from the duct or lobular, we also look at 3 common receptors, which is estrogen, progesterone, HER2 receptor. So from these 3 receptor status, we divide them into 3 groups. So hormone receptor positive type, HER2 enhanced type, and the triple negative subtype. Previously, when I tell my patients, when you have breast cancer, treatment is 5 components: surgery, chemotherapy, radiotherapy, targeted therapy, and endocrine therapy. But nowadays, based on the cancer subtype, we may tweak our treatment, right? So
true.
I would actually refer to you earlier for neoadjuvant chemotherapy to downsize the tumor, to treat the cancer with chemotherapy first, with neoadjuvant therapy, then I proceed with surgery.
The most common, the 60%, is the hormone receptor positive type, when the estrogen hormone actually feeds the cancer cell, making the cancer divide and survive. So in this patient, they commonly have surgery first, right? And then the high risk one will get new treatment, which is targeted therapy, tablets for 2 years, together with the estrogen hormone. The second subtype is HER2 positive breast cancer, which makes up about 20% of the patients. So the cancer is actually active because of this HER2 protein at the surface of the cells. So in this patient, even if the size is small, for example, like 2 centimeter cancer tumor, we can already start with upfront treatment, which is consisting of chemotherapy and anti-HER2 antibody. But nowadays we have subcutaneous or injection under skin preparation, which is quite common.
Easy for them.
It's easy for them to use.
They don't have to be admitted then.
Yes. So they will have about 4.5 months of treatment before the surgery. So about 6 to 8 cycles. And they have surgery, and then following which they will continue with antibody treatment alone for up to 1 year. So in the third subtype, which is triple negative subtype, the cancer cells is not because of the hormone and not because of the HER2 protein active tumor. For this type of subtypes of cancer, we use immunotherapy up front. So from as small as 1 centimeter tumor, we can already use immunotherapy combined with the chemotherapy before they have surgery. So they will have that for 6 cycles, so about 4.5 months. Immunotherapy actually enhance patient's own immune system to fight or to kill the cancer cell. In breast cancer, we don't use it as a monotherapy, so treatment on its own. We use it as a combination with the conventional chemotherapy. But the chemotherapy will only be for 6 cycles or 4.5 months, and then they can continue with the immunotherapy.
Yeah, I mean, in a way, not only I suppose the treatment for chemotherapy and targeted therapy is, we are making it more simplified for patients.
Yes.
So that they can actually take it as a daycare procedure.
Yeah, daycare procedure.
Even with surgery nowadays, we talk about newer things like intraoperative radiotherapy. Basically, these patients would actually benefit from not only downstaging the cancer, from making from a big cancer, we can actually make it smaller.
Yeah.
We can actually save their breast.
Yes.
So in that sense, in terms of surgical approach, it's a lot better. So you can actually have a nicer cosmetic outcome with a white local excision.
Yes.
A breast conservation surgery. And then sometimes you can even like reduce your axillary dissection in surgery. So instead of taking out all the
lymph nodes,
a lot of lymph nodes, like 10, 15, 20 lymph nodes, you actually take out like less than 4.
So that is called sentinel
node biopsy. So you actually minimize, we call it problems related to surgery, the morbidity with this new therapy. When we perform breast cancer surgery, it's often divided into 2 types. You either save the breast by doing breast conservation surgery, versus taking out the whole breast. So there are certain cases where you can't do breast conservation surgery. But in cases where you have to offer them mastectomy, we will actually also talk about giving them a new breast. And that's called breast reconstruction, which is commonly practiced. It is available in a lot of hospitals, a lot of centers, and we aim to give them back their natural appearance as much as possible. In a traditional manner where you do whole breast radiotherapy after surgery, nowadays with intraoperative radiotherapy,
you do it during
surgery. Okay. So patient doesn't have to come back to hospital every day for
to complete the radiotherapy course.
So it's done only one time
during the
operation.
Okay. With all this treatment, whether it's targeted therapy, antibody, or immunotherapy, they still be able to stay active and maintain their lifestyle and survive longer.
So, but again, like all this new treatment is only suitable if you are early stage. So it would be best if you can come in early and if you can detect the cancer early. If possible, we want to detect the cancer before the symptom even starts. So I think the key is screening, screening, and screening.